Seeing the results you expect, it can be really disheartening, feeling like you're working incredibly hard but still falling short somehow.
It really can. That's a frustration we hear, well, quite a lot, actually. Trainees dedicate hours poring over notes, guidelines, but often the issue isn't really the sheer amount of work. It's how that work is being done.
Exactly. We see so many trainees focusing maybe too much on just memorization, trying to absorb every single detail of every guideline. And I mean, it's understandable, isn't it? There's just so much information. But the AKT, and maybe more importantly, just being a really good, safe GP, it's not just about recalling isolated facts. It's much more about how you use that knowledge in practice.
That is the absolute key difference. Yes, you need to know things like drug dosages in the BNF. That's kind of a necessary foundation. But it's just not enough on its own to effectively manage the complexities you'll face in a real GP consultation or to navigate the scenarios they throw at you in the AKT.
Right. So today we're diving deep into that really crucial shift, moving from simply, memorizing stuff to truly applying clinical reasoning. Our goal here is to equip you with strategies, not just to know the facts, but to really understand how they fit into the real world of patient care. Think about, say, advising someone on the risk of contraception failure. How do you weigh up the evidence? How do you communicate that clearly? Or maybe consider a patient asking about a PSA test. How do you guide them through all the uncertainties, the potential outcomes? These are exactly the kinds of scenarios where that applied reasoning is just paramount.
And that's precisely what the AKT is designed to test. It's testing your ability to integrate knowledge, evidence, guidelines, to make safe and effective decisions in those everyday GP moments.
Okay, so let's unpack that a bit more. Why is just trying to memorize everything for the AKT, why can that be so problematic? What are the real downsides?
Well, like we said, the AKT uses clinical scenarios. They demand you understand the context of your knowledge. It's not just asking for, random facts pulled out of thin air. For instance, knowing the diagnostic criteria for a condition, that's one thing. But understanding when to suspect it in a patient who comes in with maybe vague symptoms or what investigations are appropriate, and crucially, in what order, and knowing when you need to involve specialist input well, that requires a much, much deeper level of understanding. Just knowing the list of criteria won't get you through that real-world complexity.
Yeah, it's like having all the jigsaw pieces scattered on the table, but not actually seeing how they connect to form the bigger picture of that patient's health journey. Have you ever found yourself in that situation where you knew a fact, you knew a guideline, but then in the heat of a consultation, you weren't quite sure how to apply it to the specific person sitting in front of you?
Oh, absolutely. I think many trainees can probably relate to that feeling. You remember a specific statistic from a study, perhaps, but then really struggle to explain its actual relevance to a worried patient. Explaining it in a way that helps them understand their own situation and make properly informed choices about their care. That's the hard bit.
So, if pure rote memorization isn't the most effective path, what are some maybe evidence-based revision strategies that more closely mirror the kind of thinking we actually do in our daily practice as GPs?
Well, one approach I find particularly helpful is cultivating a kind of clinical curiosity journal. Think of it as a space to just jot down PUNs. That's patients' unmet needs, those questions or areas of uncertainty that pop up during a consultation. And also DNs, demonstrated educational needs, those moments where you realize, I have a gap in my own knowledge here. This immediately anchors your learning in real patient encounters. It makes it far more relevant and, frankly, much more likely to stick.
That's a brilliant way to make learning really practical. So a PUN might be, say, a patient asking about a less common side effect of a medication you prescribed, something you need to look into afterwards.
Exactly.
And a DEN could be realizing you weren't entirely sure about the latest guidelines for managing, type 2 diabetes that came up in your last clinic. It makes the revision so much more targeted, doesn't it?
Precisely.
What other practical strategies can help bridge that gap between just knowing stuff and actually applying it?
Yeah, well, don't underestimate the value of just debriefing with your trainers. Really use those opportunities. Discuss the cases you found challenging or maybe where you just felt a bit unsure. Asking things like, why did you make that specific decision? Or how did you weigh up those different factors can give you such invaluable insights into the applied reasoning process. And it's in a safe learning environment, too.
Okay, and what about for those incredibly demanding days? The ones when finding big blocks of study time just feels completely impossible?
Ah, yes, that's where embracing micro-learning can be a real game changer, seriously. Instead of feeling that pressure to sit down for hours after a really long shift, Try to leverage those brief moments you get between patients. Even just a quick 2-minute check of a reliable source like nice CKS, just to clarify a point that came up in your last consultation that can be incredibly effective. It's about addressing those immediate knowledge needs in a really time-efficient way.
Absolutely. So it's really about connecting your learning directly to your clinical experiences, yeah.
Mm-hmm.
Actively seeking clarification from experienced colleagues and using those small windows of time to reinforce key learning points. Okay, now let's talk about some specific evidence-based resources that can really support this shift towards applied learning. Where should trainees be looking?
Right. There are several essential resources that should really be your go-to. First and foremost, you've got the NICE and SIGN guidelines. They provide the evidence-based recommendations for a huge array of conditions. But, and this is crucial, it's not just about reading the recommendations themselves, it's about understanding the evidence that actually underpins them. You need to ask yourself, why is this the recommended approach? What evidence were these guidelines actually based on? What are the alternative options, and why might they be less preferred in most cases?
That's a great point. Really engaging with the why behind the guidance, not just the what. What are the key resources should trainees have on their radar?
Okay, so the BNF is obviously crucial, particularly the sections on prescribing and drug interactions. But again, it's not just about knowing the dose, is it? It's understanding the indications, the contraindications, potential side effects, how different drugs might interact, especially in a patient with multiple comorbidities, all those complex factors you consider in a real consultation. Keeping up with journals like the BJGP and InnovAiT can also offer more in-depth perspective, discussions of current issues in primary care. They're really useful.
Definitely.
And don't forget resources like the Drug and Therapeutics Bulletin for that concise, independent advice on treatments. And finally, you really need to be familiar with the legal and ethical frameworks, things like the Mental Health Act, the Mental Capacity Act, and of course, the DVLA guidelines on fitness to drive. These come up so frequently in practice.
We mentioned the Cochrane Library earlier, and I know some trainees might feel it's a bit too research heavy, maybe too detailed for exam prep. What's its real value for applied learning in general practice?
Yeah, I understand that perception. While the Cochrane Library does contain very detailed systematic reviews, its real strength for a GP trainee, I think, lies in developing your critical appraisal skills and really understanding how evidence informs clinical decisions day to day. It's about learning to weigh the strength of the evidence, understand the specific outcomes that were measured in studies, and importantly, consider the applicability of those findings to your patient population.
Okay, could you give us a specific example? Like how engaging with a Cochrane summary could actually shift a trainee's understanding in a way that's directly relevant to their practice and, the AKT?
Sure. Let's take a common scenario, like managing acute sore throat. A Cochrane review might summarize the evidence on how effective antibiotics actually are for reducing symptom duration or preventing complications like quinsy. By engaging with that review properly, you move beyond a simple give antibiotics for sore throat kind of approach.
Yeah.
You start understanding the nuances, like when are antibiotics most likely to be beneficial? What are the real risks of antibiotic resistance we need to consider? How does this evidence actually inform a risk-benefit discussion with a patient who might be sitting there expecting antibiotics? This ability to critically evaluate the evidence and then apply it to a common presenting problem, that is exactly the kind of applied reasoning the AKT is assessing.
That makes perfect sense. It's about developing that critical lens, isn't it? And understanding how research actually translates into practical patient care. Right. Now, let's talk about a specific tool that's really designed to help trainees develop this applied reasoning, MCQ Vault. You mentioned it earlier.
Yes, MCQ Vault. It's really designed from the ground up to be more than just a sort of repository of practice questions. The way the questions are structured, and especially the accompanying explanations, they're really focused on helping you think like a GP.
So what are the key features then that make it more of a thinking bank, as you put it, rather than just another question bank?
For me, the most valuable aspect is the detailed explanations. They're provided not just for the correct answer, which is helpful, but crucially for why the incorrect options are wrong. This really forces you to actively engage with the reasoning behind each potential answer. You start to understand the nuances of diagnosis and management much better. It's almost like getting insights into the thought process of an experienced clinician walking you through it.
Oh, that's so important, isn't it? It's not just about spotting the right answer. It's about understanding why those other plausible-sounding options are actually not the best choice in that specific clinical scenario.
Exactly right. And then you've also got the Vault Pearls. These are concise, evidence-based teaching points, and they're directly linked to current guidelines. They offer those key little pieces of information and updates that you can immediately apply to your understanding of clinical cases. The overall aim really is to train your diagnostic brain to develop that systematic approach, assessing a patient, considering different possibilities, weighing them up, and then arriving at the most appropriate course of action. Just like you would in a real consultation about, say, contraception failure risk or trying to help someone decide about a PSA test.
Okay, but one big concern trainees always have with any question bank is, well, are they up to date? Does the content keep pace with the constant updates and guidelines and best practice? How does MCQ Vault handle that?
That's a really valid point, and it's super important. MCQ Vault actually has a robust monthly audit and refresh process in place. They actively review and update their questions, their explanations, the Vault pearls, to make sure they align with the very latest NICE, GMC, and RCGP guidance. So this gives you the confidence that you're revising with material that genuinely reflects current evidence-based practice. You're not learning outdated stuff.
That's definitely reassuring for trainees. Okay, now, we've talked a lot about guidelines and resources, but there's another area that's absolutely vital for GPs and ties directly into this applied reasoning idea, and that's understanding basic statistics. Why is this so important in our daily practice?
Yeah, stats. Statistical literacy in general practice isn't about, becoming a statistician or performing complex calculations yourself. Not at all. It's really about being able to interpret information and, crucially, communicate information about risk and benefit effectively and clearly to your patients. Think about explaining the effectiveness of different contraceptive methods, yeah? Or interpreting the results of screening tests like mammograms or cervical smears, or discussing the potential benefits and, importantly, the harms of something like a PSA test. In all these common situations, you're dealing with probabilities, with uncertainty, and the need to help patients make genuinely informed decisions based on that information.
Right. So it's about translating that often quite complex statistical information into clear, understandable terms for our patients, making it meaningful for them.
Precisely. As a GP, you need to be able to understand what the numbers actually mean in the real world, and then how to convey that information accurately. And importantly, without causing unnecessary alarm or, conversely, false reassurance. This connects directly back to applied reasoning, doesn't it? You're using your understanding of the data to guide your communication and facilitate that shared decision-making, all within the context of a real consultation.
Can you give us an example? How does a basic understanding of stats play out when discussing a common GP scenario, like contraception?
Okay, take the contraception example. It's much more impactful, much clearer to say something like, for every 100 women using this method perfectly for a year, about one might get pregnant, rather than just stating a percentage efficacy, like 99% effective.
Mhm.
Using those absolute numbers, those natural frequencies, really helps patients to better understand their individual risk. It makes it more concrete. And it's equally important to frame both the benefits and the potential harms using similar metrics, so patients can make a properly balanced comparison.
Yeah, that makes the information much more tangible for the patient, definitely. What about when we're looking at research findings, maybe from a new study, that might influence our practice? How do we figure out what's truly relevant for our patients from that?
This is where understanding the difference between statistical significance and clinical meaningfulness is absolutely crucial. A research study might find a statistically significant result, meaning it's unlikely to be just down to chance, but the actual effect on patients' health might be so small that it's not really meaningful in a clinical setting. It doesn't change things much for them.
Right. You gave some good examples earlier, didn't you? Like a statistically significant, but actually very tiny reduction in pain with a new treatment. Or maybe a small change in a lab value that doesn't actually translate to any real improvement in how the patient feels or functions.
Exactly. And when considering something like PSA testing, a study might show a statistically significant difference in PSA levels between, say, screened and unscreened groups. But if that doesn't translate into a meaningful reduction in prostate cancer mortality, or maybe a significant improvement in quality of life down the line, then its clinical significance is really questionable, isn't it? Understanding this helps you focus on evidence that will genuinely make a difference to your patient's well-being, and it fundamentally informs how you counsel them about their options.
Okay. And how do concepts like confidence intervals fit into this in a practical sense for a GP having these conversations?
Right. Confidence intervals, particularly the 95% you often see. They give us an idea of the range within which the true effect of an intervention or an exposure is likely to lie. It's a way of showing the uncertainty that's inherent in research. So, when you're discussing potential benefits or risks of a treatment with a patient, let's say, the potential reduction in risk of a heart attack with a statin to fortune. Understanding the confidence interval can help you communicate the range of possible outcomes. It helps you avoid just giving a single, possibly misleading point estimate. It provides a more honest and nuanced picture of the evidence we actually have.
So it really all comes back to being able to interpret the evidence, understand its limitations, the uncertainties, and then communicate it effectively in the context of that individual patient consultation. Whether you're discussing contraception options or the complexities of PSA testing.
Absolutely. Always frame your learning with that question. How would this appear in a consultation? Whether you're reviewing NICE guidelines, reading a Cochrane summary, or working through those MCQ Vault questions, constantly think about how that specific piece of knowledge would inform your discussions with patients and help you facilitate genuine shared decision-making. Remember, these resources, they aren't just about passing the AKT exam. They're fundamentally about building the critical thinking skills you need every single day to be a safe, effective, and evidence-based GP.
Okay, so to summarize then, what's the key takeaway message you really want our listeners to remember from this deep dive?
I'd say focus on studying smarter, not just harder. Prioritize understanding the evidence, the reasoning behind the guidelines, rather than just trying to memorize lists of isolated facts. Think application.
And what's one immediate step they could take, maybe today or tomorrow, to start applying this approach?
Okay, well, when you next engage with a guideline or maybe a research summary, actively ask yourself, what's the actual evidence behind this recommendation? How does it really apply to the patients I see in my clinic? And crucially, how would I explain this clearly to someone in a consultation? And definitely explore MCQ Vault as a tool specifically designed to train that applied clinical reasoning. Remember the value of understanding why the incorrect answers are wrong, and look out for those concise, up-to-date Vault pearls.
And for those who want to check out MCQ Vault for themselves, where should they go?
Yep, just head over to mcqvault.co.uk to support your AKT revision.
Great. And maybe as you go into your next study session or even see your next patient, really try to think about how you can focus on the why behind the information, not just the what. Perhaps pick one specific guideline or one piece of evidence and explore it with that direct focus. How would I apply this in a consultation I've had recently or when I anticipate having soon?
Revise with purpose, practice with confidence.